All right, so pain, it's the sixth vital sign, correct? Okay, so pain serves many purposes. It tells us basically something's wrong. Yeah. So if you feel pain, there must be something wrong with your tooth, with your head, or whichever part of your body. So it's a good and bad sensation. Yeah. Bad because we don't want to feel pain, but good that it warns you, right? That something is wrong. Let's say it preserves body function as well, protects you from injury. Let's say when you touch something hot, it's painful. Yeah. So you withdraw from the pain. So it serves a protective purpose as well as again diagnostic purpose. Yeah. Otherwise, if you don't feel anything, then you'll just continue with the injury or the disease process. But we don't have to live with pain, though. It's something people have to understand. The nurse's definition of pain is from Margot McCaffrey's definition, which is purely subjective. So here is the definition for the American Pain Society, but our nursing definition of pain is right, whatever the patient experiencing it says it is, existing whenever they say it does. So because of the subjective nature of the pain, is there evidence of pain? 9. I repeat, because of the subjective nature of pain. So if you accept that there is no evidence of pain, will you ask the patient to prove that there is pain? No, because we cannot disprove it either. So the best reliable measure of pain is simply the patient's subjective report. Of course, we have to consider also for patients who are nonverbal or unable to communicate or express their pain, whether it's because of a cognitive decline or let's say they're unconscious, for instance, then we have to look for certain cues. Okay, so there are behavioral expressions of pain. This would come into use when we get to pain assessment. Okay, so we will use not different types of pain assessment tools in order to assess all types of patients. There's one for every patient. If you have problems accepting this definition of pain, then you'll have severe difficulty managing somebody's pain. Okay, I'll give you an example. So I worked with a retired, no, she wasn't retired yet, obviously, but she's near retirement. She was from Forest Hills. So I met her in Florida. We worked together on a med-surg unit, and she had very little tolerance for people who are uh, drug seekers. We label certain patients because of their behavior. So we have in that hospital, we were a 3 hospital system, meaning it's a tri-county area, and we have like 1, 2, 3, 4. We have 5 hospitals in the 3 counties, and these 2 brothers are known to all 5 hospitals. They shop around. Okay. They'll probably go to this hospital, consecutively, and then when they get in trouble, so let's say the deputies come because they threaten the doctor, then they'll go to the next hospital and do the same thing. Okay, so so when they come, it's always a preconceived notion that, oh, this guy is here just causing trouble, right? So anyway, so when the patient was complaining of pain, rang the call bell, and I was about to go answer the call bell. And then we didn't have charge nurses, we had team leaders, meaning we rotated who's the team leader. Okay, so it wasn't just one person always taking charge. So Kathleen was team leader that time. Then she stopped me. She said, "No, no, no, Roger, get back in your seat. I'll handle this." So when she went to the outside of the door, so she looked back at me and then called me and said, "Roger, watch this." And then she talked to the patient from the doorway, okay? Hey, what do you want? And then the patient said, I'm in pain. And then Kathleen said, no, you're not. I don't want any of this bullshit tonight, right? I don't want to have to deal with your crap, right? And then that's it. For the rest of the night, the guy never rang his call bell for anything, right? So was that the way we should treat pain though? No, obviously, even for those people who are, again, we cannot disprove, right, that they are not really in pain. Okay, so it's purely subjective.
Did you disagree with her that night? What did you tell her?
Well, the guy didn't call again, so that's what I documented. I wasn't lying.
No, what I'm saying,
Right.
did you agree with her tactic, like by,
Of course not.
oh, okay, all right,
But was it effective?
yes, in some way.
I mean,
Yeah.
but again, it wasn't, the guy had every right to complain, right?
Uh-huh.
Yes. So I'll just put it like that. Don't get any ideas though. That's not how we handle, all right? Okay. Effects of pain. So it affects the entire body, especially the mind, not just your um physical body, but your well-being. Yeah. I mean, you can't concentrate when you're having to constantly deal with pain. It affects mobility. And then once your mobility is affected, then there will be complications of immobility. Okay, so it can snowball over time. Not to mention, it will have because what will tend to happen when you're always in pain? What happens to your respiratory effort? Yeah, because you always tend to hold your breath, right? Just to deal with the pain. And then over time, that affects your cardiac function. And no, because you're always having these high serotonin levels and high, what's the pain transmitter? Prostaglandin. Okay, so these neurotransmitters at high levels can wreak havoc in your organs over a period of years. There are different types of pain, so we have to do a complete assessment so that you can effectively treat the pain. Don't just go, oh, the patient's complaining of pain, and then you ask for the number, and then that's it. You go to your MAR or call the doctor for a Tylenol or whatever you want. Okay, so the a pain assessment must be completed each time so that you are treating the pain appropriately with the correct medicine or non-pharmacologic means. Let's start with nociceptive. These are physiologic types of pain, meaning there's a physical cause of the pain. Let's say you had surgery, or let's say you experienced trauma, including surgery. Okay? Or there is a disease condition, some inflamed part of your body, appendicitis, for instance, or any other organ or muscle. Okay, so these are nociceptive type of pain. Neuropathic, however, is if we call nociceptive as normal, meaning there's an injury, actual injury, and those injured cells release pain neurotransmitters, then that's what we call normal pain pathway, meaning there is a reason, an actual attributable reason for the pain. Neuropathic, however, is different. The patient experiences pain, but there is no physical or obvious reason for the presence of the pain. Okay, so these are what we call abnormal pain processing. Types of pain like this are usually, for example, you've heard of phantom limb pain? Okay, another example is from sciatica, for instance. Okay, so that's another type of pain that's neuropathic. And there's also fibromyalgia or pain from shingles as well. So these are neuropathic types of pain. So therefore, since they are abnormal pain processing, your traditional pain medications will not be appropriate here, meaning we usually give these patients non analgesic medications, but rather we'll use anti-seizure medications, antidepressants, because these are what works better for neuropathic pain. So that's why it's important to assess your pain comprehensively so that you can give the doctor enough information and they can prescribe the appropriate treatment for your patient's particular pain. So these are the systemic effects of pain. As you can see, it's all over the patient's body systems. Most important of all is the quality of life. It's not good to live with pain. We may never fully understand this unless you're actually feeling what the patient is experiencing, living the life that they are. So sometimes it's hard to put enough emphasis on the pain, and sometimes we also don't treat it with the sense of urgency that they should be treated, because we're not the ones experiencing it. You see what I mean? And also, don't label your patient and your family for feeling or behaving certain way. For instance, when you're, let's say, starting an IV, for instance. Okay, I know you guys are excited, yeah, about starting IV, sticking people. You like that idea, yeah? Okay, it's a painful experience, okay? Especially if you have to do it repeatedly. As a new nurse, you may struggle um, with getting the catheter into the vein. Don't worry, I work with a lot of people who still suck to this day, even after 30, 40, or 50 years of nursing. Okay, some people are just not gifted with the skill of starting IV catheters. Okay, and they accept that. Okay, they accept it. They don't try to hide it. They just say, I just don't. Yeah, I'm just not good at that. Okay, they're good at everything else, but not at certain things. Right? And then you don't know that you may be talented. Let's say you discover once you do it once or twice and say, "Oh, hey, I'm good at this," right? And then you volunteer. Okay, so if people are struggling because how does it feel? You're being stuck repeatedly. Okay, and then how will the family member react, right? Watching their loved one, let's say it's your mom being stuck, and then you are the nurse, and then your the family member, the daughter, for instance, or the mom is watching their poor loved one being stuck repeatedly. So how do you think they'll react? They'll be, of course, they'll be very protective. Okay, they'll say, "Hey, stop this right now," and then they'll raise their voice, right, and say, "Find someone who's good at this." Okay, you suck now. Oh my God! And then they'll be hysterical. Some of them will actually act out and even touch you, right? So, but just realize that they're just being human. Okay, so they are, and then don't let it get to you either. Continue doing your job. Okay, so don't get flustered. Now you're sweating, and then they're making you nervous, and now you can't really do it anymore. All right. This part of the chapter is not testable. um this is just to explain how pain occurs. Let me switch to